I am Dr. Tamer Seckin, reporting from Osaka, Japan. We are at the annual meeting of ISGE. There are many beautiful presentations going on. Among some of them, we are proud to present to you and bring it through the internet. And today I have Professor Timur Gurgan from Hacettepe University, Ankara, Turkey. He is going to talk to us with some special questions with respect to endometriomas, whether surgery or conservative treatment, and its effect on IVF cycles. Timur, it's nice having you here today.
It's nice to be with you, Tamer.
My question is to you, after so many years and the results that we observe on endometriosis treatment without endometrioma first, the effect of laparoscopic excisions is well established. But when it comes to the issue of endometrioma, even though we did believe that in the past there was solid effect and positive effect of endometrioma removing or devoluming the ovary, on your presentation today you have brought some controversial results reviewing the literature and your current findings. Could you just give us a synopsis of what you have said and why and where are we going with the subject?
As a gynecological surgeons, nowadays we are just operating the endometriomas. If they are big enough to be operated, we consider the size just more than 3 to 4 centimeters. I think we have to think about the operation. But on the other hand, if there is really severe pelvic pain, we have to consider the operation as well. Today, in my presentation, I didn't touch to the operational side at all. If there is the adnexal mass and the pelvic pain, we are right to operate them. But the infertility is the question. We have to be very careful for the operation, since there are some possibilities that we have to think about in advance. The first one is, okay, we could operate the patient, and after the operation we could get around 50% of pregnancy rate in a period of time. But we have to give the patients a good advice depending upon their own characteristic that I've said today, because we cannot announce easily publicly that, okay, we could operate and we could get the 50% of pregnancy rate, because we have to individualize the what we are saying to the patient. This is the first part of my talking. The second one was the debate on if operating the patient we could decrease their IVF chance or not, because there is a question in the literature saying that if we operate the patient, remove the endometriomas, we may decrease their potential to produce the egg on the operated side. So, reviewing all of the literature, including our publication, 2 publications coming from our department, we could say that, okay, if a patient has the endometriomas, and we diagnosed the endometriomas and we decided for the IVF, the question is when we are going to operate, or should we operate those patients just prior to IVF to have a positive impact of their IVF success. Okay, and the results is 1. Okay, we don't have to operate them for sure. If there is no pain, if there is no big endometriomas, and operation cannot improve the pregnancy rate. But negatively, if we are not kind enough, if we are just using the bad techniques of removing the cyst wall, not carefully, of we are just using too much electrical energy to make the hemostasis, there is a possibility to decrease the number of the oocyte on the affected site.
Let's pause there. This is an endoscopy meeting. I think the most important part of meeting for the viewers to understand, with the respect of the results, what is the right technique for endometrioma surgery.
Yeah.
So, first of all, you probably want the viewers to be aware that we endoscopists do not use any electrical surgery on the ovary.
Yeah.
And we want to avoid it as much as possible.
Right.
We do like to take cyst wall out, because
Yes.
that's an endometrioma, secondary endometrium cavity within the abdominal cavity. So we want to take that without, though, any coagulation.
You're right that, during the discussion period, we had a debate with Michel Cani from France. We come to a conclusion that, if you are the experienced person, if you are going to the experienced surgeon, there is no problem at all. This is very, very important, and the surgeon should make the strip of the capsule in the right plane, and you don't cause any bleeding at all. So you should not use endocoagulation. So you cannot make the harm to the oocyte which is retrieved after the IVF. But the important thing is, and we all know that the recurrence rate of the removed endometriomas is a little bit higher, up to 30%. And at least we have to give the patient that they should not be operated again and again, repeatedly.
So repeat operations are, patients with repeated operations are bad candidates for.
Yeah, but the important thing is if it's the bilateral repeated operation, there is a chance of reduced oocyte. On the other hand, if there is no problem of the small endometriomas, we don't have to operate them in advance just prior to IVF.
And last questions for the sake of this meeting. I think, do you reapproximate the ovarian tissue after removing endometriomas of larger than 5 cms? Let's put it that way.
Yeah, but there are some publication in our hand. It depends upon the size of the endometriomas. If they are not big enough, we don't put any suture. We don't make anything, and there are some surgical techniques, and you could put very less amount of the electrocauterization, make the diversion of the ovarian cortex. If it's your selection and preference, if it's a big area, and we may put very fine sutures, one or two, only the approximate.
Do you suspend ovaries at times of severe pelvic side wall lesions?
Yeah, but I don't do it. I'm not a surgeon doing too much, very extensive operations. But and there is a question if we should prepare the ovaries just prior to IVF to get
technically it's difficult
to get oocyte, and we don't need them very often.
Thank you very much.
Thank you very much, Dr. Tamer.